afternoon, everyone. Good afternoon, everyone. This room is cold, though, Dr. Peter. It's not like ACS room. Okay. All right, I'm going to be taking you out of pediatrics to just a little snippet on what cardiology looks like, and use that as a way to invite you in December, first week of December, for the highly acclaimed Abuja Cardiovascular Symposium, the 10th edition, 10 years on. So when you are there for that one, I will go into detail of some of the things we'll talk about. Then we will learn about basic life support, advanced cardiac life support, ECG, hypertension, heart failure, and then extra things on cardiac surgery. We will teach you all of that in December. 2-day course, 10 CME points for everyone. And for the nurses, I forgot how many CME points, but the full CME points for the nurses. So I want to invite you. My name is Iseko. I work in Cardiocare and Limi Hospital. I want to give you a snippet into interventional cardiology. And Cardiocare is one of the hospitals, just like Limi Children's Hospital, who is organizing this symposium. And it's a National Center of Excellence in Cardiovascular Care, award from the Nigerian Cardiac Society, and located in Abuja. I just left there where we've been operating through the night, and then I've been operating this morning. If not, I'll be here much earlier to talk with all of you on many other things. I'm so excited to be here for the 5th Abuja Perinatal Symposium. And the idea around the Perinatal Symposium is babies should not die at birth, neither should mothers die at birth. And the people in this room are those that will change Nigeria, that will make Nigeria what it's supposed to be, that will make the babies and give them a chance to survive. Nobody can speak up for them but those of you in this room. And I'm so grateful for all the beautiful faces, the excited people that are here to come and learn, to come and relearn, and to come and unlearn, so that we can move our great country much forward. So, Cardiocare has been performing many procedures. We're a support and reference hospital, and our aim is to reverse medical tourism. Right now, we are doing open heart surgeries every day, all day. We had one through the night to this morning. I've just left the theater now. That is why I'm not wearing a suit like most of you. For somebody that had a heart attack from Sokoto, all the way from Sokoto coming in here. So we do a lot of things: coronary angio, pacemakers, ICDs. Anytime somebody has a heart problem, they don't need to travel abroad, except they want to snap with Oyinbo. But if they don't mind snapping with us that are not Oyinbo, yes, they'll get equivalent care by the grace of God. All right. So let me show you a few cases that we've managed. 43-year-old diabetic, hypertensive, ECG showed a number of things there. How many of us can read this ECG? If you were there in December, don't hide. Don't hide. Some of you, I can see your faces. Should I call you out? Oh yeah, now try. Somebody should try. Somebody should try. No matter what, when you leave this place, you should be able to try and get some of these things. Yes? Who's going to try? Okay, let's not waste time. They came here for pediatrics. They did not come here for anybody to harass them. So, can you see here that there's an ST elevation? See it, a big square up there, right? I'm sure some of you that were there can remember. For those of you that were there that can't remember, that ate our rice and moi and left, God forgive you. The rest of you, please go back to our YouTube channel, Cardiocare YouTube channel, and rewatch it. It will be life-saving. And so once we see an ECG like this, that has this kind of ST elevation, see the line that you should have been and see how high it is. Most of these patients come in complaining of ulcer. So when you see an adult, especially with diabetes or hypertension, complaining of ulcer, please do an ECG and get it interpreted if you cannot do so yourself. So if I don't learn anything today, at least learn this algorithm. Anybody that comes with chest pain, within 5-10 minutes of coming in, and you could get this algorithm for your clinic if you want. Just ask them at the back, they'll send it to you. Or if you're in the WhatsApp group, just say hi in the WhatsApp group. You want the chest pain algorithm, I will send it to you. Within 10 minutes of anybody entering your room, they should have, with chest pain, they should have an ECG. 10 minutes. What did I say? 10 minutes. You should not be hidden or locked in matron's office or in the CMD's office. Okay, it should be there. Everybody should be able to do it within 10 minutes. The next thing you ask yourself is, does this person have a high risk for a heart attack? If they have no hypertension, no diabetes, no high cholesterol, they are young, and no family history of cardiac disease before 40, then they probably are no cardiac risk. If they have one, either hypertension, probably are one. But if they have diabetes or any other hypertension or cholesterol, then they are high risk. In all of them, you must do their ECG immediately. In those with high risk, whether the ECG is normal or abnormal, you must take their blood test and check for their cardiac enzymes. The cardiac enzyme that we use is called what? Who knows it? Troponin. Troponin. So you must do a troponin test. You don't know how to do a troponin test, you don't have the team, please get somebody get a place that can get it done immediately. The troponin test literally takes 15-20 minutes. Even if you cannot read the ECG, the troponin test will tell you whether it's high or low. At that point in time, you're dealing with a heart attack. 50% of people with a heart attack will die within 1 day. 50%. Another 30%, another almost 20% may die within 30 days. So you don't want to play around with it. All right, you want to get them as quickly as possible to a cath lab, and Cardiocare is perhaps the premium pioneer place in Abuja and Nigeria. So you have echocardiogram and that, and if it's positive, straight to the cath lab. And if it is negative, if your ECG is negative, troponin is negative, and the person has a high risk, either hypertension or diabetes, please don't send the patient home. Wait for another 6 hours and repeat it, except there are other things. So except you've had a specialist say, don't worry, there's nothing there, please wait for 6 hours. One negative result is not enough. Beautiful. So I'll move forward. So this man now, we're talking about the 43-year-old man, came with that ECG, and we know that definitely he's having some chest pain. That's Cardiocare if you've never been there before. And definitely, immediately, we'll do our ECG, we'll do all these tests, and straight away, we go in. Very simple, you can do it. Put the needle inside the femoral artery, pass your catheter into the heart. Don't kill anybody, or you can't do it. All right, and then I'm sure you can see the blocked vessel there. Can you see it there? So this case has opened up partially. Most of the cases are 100% blood. Then we put our blom. Can you see the blom? And it opens up. Then we put our stent. Okay, we don't use syringe to do it. We use that thing we're turning to raise the pressure gradually, and that is how we are putting the stent and the balloon there. So we put the area, and afterwards it's opened up. Almost immediately, especially when they are coming early, chest pain disappears. Almost immediately, heart gets blood back, and you really want to get this. The best time to do an intervention after chest pain and MI is within 3 hours. In fact, when they get to your hospital, internationally, they should be in the cath lab within 60 minutes. If you think you cannot get them to a cath lab within 60 minutes, then there are other things you must do. So if you're on the group, you can always call for help. You can reach out to us at Cardiocare. We'll direct you on what to do pending when you can get there. Then we had this 41-year-old. I hope you are looking at the ages. They are not looking old, Abby. They are young people. I think the man I did in February was 1 year or 2 years my junior in secondary school. So it's around us. It's everywhere. So he came with this severe chest pain. Christmas Eve, I had to leave my enjoyment and come out, leave the chicken. Anterior STEMI, chest pain. So again, we take our catheter through the femoral artery and we go to the heart. The person is awake. And in this case, unlike the other one, there's 100% blockage. It's supposed to have come like this all the way down. But now we have a 100% blockage. This is the left anterior descending. So we put our wire in and pass a BMW, not the car, balanced middleweight wire through it. Then we put our blom to open up the blood vessel. Can you see there's some flow now? Some flow is coming up small. Then it's not still good enough. It should be much better than this. So what do we do next? Can you see this small dot moving? That is a clot aspiration catheter. It's an export advance. We aspirate whatever blood clots are inside that coronary vessel. And you see the blood clot we brought out. Can you see this? This is very big. I mean, I magnified it. So after removing the clot, can you see the flow now coming all the way to the end? Can we see that? Still not the very best. So now we have removed the clot. There's still tight lesion there. So we put our stent, big iron stent, drug eluting. It's coated with drugs. It's not just a metal stent, okay? And then it's typically cobalt chromium. Then afterwards, we gave this thing, is still not looking very well. Then we have to give drugs inside that vessel. We give nitroglycerin, adenosine to help the blood vessel to expand. And then we dilate the proximally. So we do that. Now, can you see it? Whoa, it was not like that before, Abi. All that part of the heart was not getting any blood flow. And now it's getting blood flow. That is a life saved. All right? So this is essentially what coronary angio looks like. Thank you so much. And that's what the hospital looks like, and those are our cardiac surgery OR. And so there are so many things. How many of us can read this ECG? It looks like Jaga Jaga, Abi. If you cannot read an ECG, first of all, just go to our YouTube channel and watch. I assure you, if you watch 2 sessions, you'll be able to read. I assure you. So just go. It is contemporary. It's not highfalutin. It's just exactly what you need. And then join us in December. If you can see, you can read an ECG. And then for those of you, you can now use it and be collecting 22K to report ECG, Abi. Sharp, sharp. All right, so what we are seeing here is a normal beat, and an abnormal beat. When we have 3 abnormal beat ectopics like this, we call that a ventricular tachycardia. And maybe I don't know how many times children get that while resuscitating, and they'll teach you some of that. But you call that a ventricular tachycardia. And if ventricular tachycardia lasts longer than 30 seconds, we say it's sustained. And sometimes we say it's non-sustained. So that's the same one that is here, coming. Once it's 3 or more, ventricular tachycardia. Once it lasts for 30 seconds or more, we call it what? Sustained. Once it's less than 30 seconds, we call it non-sustained. For those of you that are keeping quiet, you have not attended our ACLS class, because there are specific things you must do if you must save that patient's life. Otherwise, your monitor in your hospital that is on patient, you could have put a TV there, it's better. You should be able to read what is happening on that. So, we did an angio for him. After the angio was normal, can we see what's happening? That thing started coming, and then we have jaga jaga. It turns to what we call a ventricular fibrillation. And here we gave a shock, and the heart comes back to normal. The man became unconscious immediately, blood pressure crashed, and then we delivered a shock. Luckily, we were able to capture this image when it happened, and then he came back to normal. And when he came back to normal, he was telling us that why are we disturbing him? Why is there so much noise around him? Meanwhile, he has knocked on heaven and come back. All right. So I know the man. He's doing very well today. He has even given birth to an extra child. This was about 2 years ago. So what do? We came to after everything, we come here just under the clavicle. We give a local anesthetic. Then we take some wires called leads into the heart. This is an ICD. The same way we do a pacemaker. We take the lead into the heart, screw it into the heart, both the atrium, typically right atrium, right ventricle. And that now starts sensing the heart. It becomes like a cardiologist in their heart. We call it like a guardian angel device. Then we connect it to it. Every time the heart wants to stop, it will deliver a shock. If that kind of thing happens in the market. And you know what? This man came back in 1 year's time with multiple shocks. He was sleeping and pam, pam, pam. The heart was trying to stop. So that shock we gave him now, this device is there protecting him. So when anybody has heart failure or severe heart diseases, we don't leave them to just go and then start praying, blood of Jesus, maybe something will happen. We give them something that constantly checks and truly does prolong life. It really does. All right, so what next? The man came with an electrical storm, and that's what we even have this. Can we see this one? I'm going to show you this beautiful one. Can we see this patient's monitor? Can you see the jaga jaga? Then all of a sudden it becomes normal again. Can we see that? What has happened in that case? This person had that ICD. And so when he started doing this, the heart rate was going to 145, and then a shock was delivered, and it restored the heart rate. Otherwise, the next thing is that collapse, cardiac arrest. These are very, very important devices that are used to save life. And they are here, right here in Abuja. There's hardly any reason for anybody to die unnecessarily. And by God's grace, Cardiocare is the first hospital in West Africa, virtually sub-Saharan Africa except Kenya, to do a left bundle branch area pacing. I think we should give it a round of applause thing. This is a pioneer status. What is left bundle branch area pacing? Anybody knows? 20,000, 50,000, 100,000, 500,000, 1 million, going, gone. For somebody. All right, beautiful. Thank you for not getting it and chopping my money. But left bundle branch area pacing is a type of pacemaker. When we put a pacemaker normally, we just connect it into the heart. But in left bundle branch area pacing, we find the wires that are running around the heart, and we put our pacemaker wire inside that wire. So when the pacemaker is working, it works almost as if it is a normal, natural rhythm. So especially people that are younger, children, adolescents that need a pacemaker, this essentially is the best way to put a pacemaker for them. And we are very happy to be able to have done that here. And this was for a 24-year-old. I still saw him recently. That is the left bundle branch area pacing. Pacemaker is in situ, small device. We put it under the skin. The guy is doing fine now, doing very well, and just a typical Tuesday in Cardiocare. All right, so, and then ICD is similar. So I'll leave all of this so that we don't talk too much. Now I'll talk about this 52-year-old. Fainting, ECG normal, echo normal, everything normal. What do you think they will say? From the village. Abi? Every time the man collapses, we check, we don't find anything. So, what else can we do? We did Holter, 24-hour ECG. We didn't find anything. So, the next thing we can do is we put this device called a loop recorder. A loop recorder can stay under the skin in the person's body for up to 3 years. So that whenever what was to happen happens, it will pick it up. So, we put it for him, and there we're able to see that he was having a complete heart block intermittently. So eventually we put our pacemaker and we defeated the village people. Abi? Thank you very much. All right. And you can see in this case, when I was in medical school, this leg would have been cut off. But you can see the anterior tibia was totally blocked. Now we put our blom and a stent. That's a stent opening up there, opening the blockage. And then thereafter, we have able to restore flow. So you can see the stent opening up. And can you see the blood flow now? Fantastic, isn't it? This is before leg. This is after. By the way, this after is about 3 weeks. Okay? This after is about 3 weeks. See how it was before. 100% blockage of the anterior tibia until we are able to open it. When we're in medical school, that is an amputation below knee. Immediately, the surgeons, in fact, maybe above knee itself, the surgeons will be very eager. 1, 2. So this is a leg saved. And this is something that we can do here. And this is one patient I remember very well. We did a stent for him. He had severe hematologic problems. So he had a stent, 2 stents, he had a stroke, and then he had severe abdominal pain. When we did the CT, he had complete 100% occlusion of the renal artery, no blood flow. But after our procedure, the blood flow is restored and able to go home the next day. What procedure do we do? That's the question. We go in, we try and aspirate the clot, break up the clot, and we deliver a thrombolytic, a drug that breaks up clots to open up the blood flow. Thereafter, we had to change his drugs, and he did very well. And the same thing we can do for the pulmonary arteries. For pulmonary embolism does not have to be a death sentence. Massive pulmonary embolism. So we do the same thing. We get our catheter into that place, get the clot out, or deliver a drug and break it in. And we're able to save life. And of course, we can put an IVC filter. So for this patient, we put an IVC filter. To stop, the IVC filter is there in the inferior vena cava. To stop further clots from the leg from going up to the lungs. Okay? I'm sure we can all see it. It looks like APC broom, Abi. All right. So, again, let me give you this final case. 56-year-old Jehovah's Witness. Of course, you know what that means. No blood. Deep femoral artery injury in one of our tertiary hospitals. They were trying to do dialysis, and somehow they injured the femoral artery, and he continued bleeding. PCV, 12%. What do we do? No blood, no open surgery. So they sent to us, and we'll do what we can do. Oh, where's my video? Tell me my video is not playing. Oh, my word. You people need to see this video. Can you click on it there for me and see what I to play? Yes, there's a video there. Thank you. Beautiful. So we can see the blockage, the flow here. Can you see it there? Spitting out, blood flow coming out. That's where the injury is. Then we put what we call a covered stent. It's a graft. And then we use it and block the area that is leaking the blood continuously. So we have there before and after. Can you see the before? And see after when it has totally blocked. When it has totally, we have occluded this thing. And that's essentially Cardiocare in a short, interventional cardiology. So cardiology has gone far. Thank you so much. Cardiology and cardiovascular practice has gone far. And now we have also been able to bring open heart surgery every day for children with holes in the heart, for adults, for those with needing coronary artery bypass surgery, and so many others. This is everyday routine and available for all of us. Nigeria can work if we put it to work. And a lot of us are here, and we shall make it happen for us and for Abuja. We pray that Nigeria will be blessed through us. Abi, Nigeria will be blessed through us. Abuja will be blessed through us. And symposia like this is to bring all of us together. Knowledge. Let us rub together and let us make it better. We will show you what we can do so that you too can go and do it in your own establishment. And please, after today, don't go back to your hospital and sit down. Find somebody and teach. That is the surest way to keep it in your mind. So keep it. My children, I will teach them whether they can hear or not. Anybody you find, you teach. Medical students that were under me, I taught them like hell, ECG, till I understood it myself. All right? So very important for all of us to go and do likewise. Of course, we do postgraduate medical training now for senior residents in cardiology. And that is what our Abuja Cardiovascular Symposium looks like. So come December, we'll be looking forward to you for our 10th edition, and everyone does not have to go abroad. Thank you very much for having me. I wish you a wonderful rest of the symposium. God bless you and have a lovely day.